Thank you for coming to this presentation. My name is Magali Cattin. I'm a PhD student at the Signal Processing Laboratory from EPFL, as he just said. We are working in close collaboration with the University Hospital of Geneva and the University of Chang in Cameroon on the project I'm going to talk about today, automatic image analysis and artificial intelligence for cervical cancer detection, a smartphone-based solution. So let's first have a look into the context of the project. So worldwide, cervical cancer is a global health burden. In 2020, it affected more than 600,000 women and resulted in more than 340,000 deaths. As you can see on the map, most of the deaths occurred in low and middle income countries, especially in Africa. The redder the country, the higher the death rate. The World Health Organization considers that the elimination of this disease is within the reach of all countries and launched in 2020 the global strategy to accelerate the elimination of cervical cancer. So, what is the cause of cervical cancer? It is actually mainly due to strains of human papillomavirus that are sexually transmitted. This means that men can also be infected by the virus and develop other types of cancer. HPV is a very common group of viruses, and most infections are usually asymptomatic and clear up without any intervention within a few months, up to 2 years. And the progression from an HPV infection to cancer usually takes 15 to 20 years. And actually, low risk types can result in warts, while the high risk types of viruses are oncogenic and are the ones that can contribute to cancers. And the progression to a cancer can be speeded up by risk factors, such as the age at first intercourse, having multiple partners, or also HIV. Though cervical cancer is a preventable disease with the anti-HPV vaccine, for instance, and it is treatable if identified early enough. To ensure an efficient management of cervical cancer screening in low and middle income countries, the WHO recommends HPV testing as a primary screening, followed by visual inspection with acetic acid, and if required, treatment. So small heads up, from now on, the slides will contain cervical images. So during a visual inspection with acetic acid, VIA, diluted acetic acid is applied to the cervix, and this provides a whitening effect that appears and disappears differently in cancerous tissue compared to benign conditions or healthy tissue. Due to its simplicity, VIA is well adapted for low and middle income countries. However, it is highly subjective because it depends on the healthcare provider's experience and training. In order to reduce this subjectivity, we are working on the development of a smartphone-based automated VIA classifier. Our technology will act as a support decision tool to assist the healthcare providers by automatically detecting cervical cancer from video based on artificial intelligence. Basically, the healthcare provider would conduct the gynecological exam as usual, applying acetic acid on the cervix while the patient is lying on the chair. But the only difference would be that they would record the process with a smartphone placed about 15 centimeters outside of the vagina of the patient. The app would then classify the patient either as positive, precancerous or cancerous, or as negative for benign and normal conditions. And secondly, it would also identify the location of the lesion. So for now, we have a preliminary algorithm based on the following data sets collected both in Geneva and in Cameroon. Initially, we had 68 patients, but we discarded 24 cases because some histological results were missing, or there were too severe movements that we couldn't compensate. The videos were blurry, too blurry. There was blood or excess of mucus. And we ended up with 44 cases, and including 29 high grades that we considered as positive, and 15 low grade or normal conditions that we considered as negative. And the data for one patient includes 120 images taken with the smartphone during the VI process, the histopathology results that we use as a reference, and that is obtained based on a biopsy, and the annotation drawn by gynecologists to identify the location of the lesion. Now, if we have a look at the algorithm itself, so the approach we use is pixel-wise, and it means that we are looking at the evolution of each pixel through time. And this allows us to work with with a limited number of data. And the first step of the algorithm is that we need to compensate movement, because even though we are using a tripod, it is unavoidable to have movement. So as you can see there, on the top row, it is before movement compensation. So the coordinates for the annotation remain the same through time in the first frame, 1 minute frame, and last frame, while the cervical image behind is moving. And if you look at the bottom row, then it is more or less stabilized. Then from RGB images, we move to grayscale images through principal component analysis. And then we select the pixels that we want to use for training the neural network. And this we do based on the annotation drawn by the gynecologists. To select positive pixels, we apply erosion to the annotation so that we don't use the pixels on the boundaries of the annotation. And for the negative pixel, we use dilation of the annotation. And so this process ensures that we don't use the pixels at the boundaries of the annotations where the subjectivity, human subjectivity, is the highest. Then we use the intensity curve of the selected pixels as input to the artificial neural network, which gives us the probability of the pixels to be positive. From this probability, we get a probability map. And from the probability map, we obtain the location of the lesion, potential location. And based on a thresholding method, then the patient is classified as either positive or negative. Now, if we look at preliminary results, our algorithm provides a sensitivity of 0.9 and a specificity of 0.87. And we compared its performance with the performance of colposcopists. The experience was made that in conditions that the colposcopists weren't aware of the histology results. So they were as blind as the algorithm to give a final diagnostic. And as you can see, the algorithm actually outperforms the colposcopists. Then here are a few examples of accurate classification. So on the top row, we have the clinical data, so the annotation drawn by the gynecologists and the histopathology result. The first case is negative, while the last three are positive. And then what the algorithm predicted. So you can see that the classification is the same, negative for the first one and positive for the last three. And the annotations are similar, even though not identical. Then if we compare our algorithm to other state-of-the-art techniques, the differences are that we're using a smartphone, while the other are mostly using a colposcope, which is a magnifying glass that is quite an expensive device to have. We are focusing we are working with 120 images because we're interested in the dynamic evolution of the VIE process, while the others are only working with a few images. And we have a low number of data for a reasonable performance. So our next technical steps. So we will increase the number of data for training. We will fine-tune the algorithm, improve its robustness, also integrate it into a mobile app so that we can then conduct a large-scale validation in Cameroon. And we are also working on a new algorithm that would overcome the limitation of the current one. And as we all know, the technology is great, but it's usually not enough. It is part of an ecosystem that involves various stakeholders with their own fears, needs, perceptions, expectations. So in our project, we have three main stakeholders involved, starting with the healthcare provider. So do they want to use a tool to assist their diagnostic? Do they trust such tool? Is this tool easy to use, useful for their daily work? Is it convenient? Is it cost and time effective? Then we have the patient's perspective. What do they think of using a smartphone as a medical device, having their cervix recorded? Does it make them anxious, stressed? And then we have all the people around the patients, so the community, the public. What do they think of using a smartphone as a medical device, of computer-aided diagnostic tools? And our goal here is to actually de-risk the technology to ensure a safe deployment later on. So in order to respond to a need and reach the targeted users and beneficiaries, we will involve the various stakeholders through the whole process of technology development. And we will study the optimal place of the test in the healthcare system and patient journey. We will study also the local stakeholder engagement to identify barriers and facilitators. And we will also study the usability of the technology. And based on these results, we will then design a deployment plan to ensure the test validation, further scale up and sustainability. So to conclude, computer-aided diagnostic could provide cervical cancer screening tests in remote areas where infrastructure and healthcare resources are lacking. And our solution reduces the subjectivity of the VIA process. It is low cost, requires minimal training before use and low maintenance, and has the potential of scaling up. So with that technology, we hope to facilitate and improve cervical cancer screening in settings with limited healthcare resources. Thank you for your attention. I'm now happy to answer any questions you might have.
Thank you so much, Magali. It was a great talk. And to be honest, I'm happy to see such collaboration between EPFL, so European University, and an African university in Cameroon, especially that it's taking into account like constraints that are on the ground, meaning low-cost smartphones, while using like AI technologies in order to provide like insights. I will have a look at the questions we have from the audience. So one question we have is, how far are we from like an implementation on the ground? Meaning, could you apply the solution in hospitals at a large scale in Africa today? And if not, what are the steps that you foresee before being able to do that?
Thank you for the question. So today it's not usable on the field yet, because what I presented is more like a proof of concept of what we did and what is possible. And so the next steps are to collect more data, to have a data set that is more reflective of what happens in the field. And then with more data, we will be able to improve our algorithm and then conduct a larger scale validation in Cameroon. And then it would be possible to scale up.
Thank you. I have a question actually from my side. Were you able to meet your users? It means doctors that are basically using the solution on smartphones in Africa, or it has been only online meetings and interactions?
So yeah, so far it's been through Zoom, but the HUG team from Geneva often went to Cameroon, so they met. And I personally hope that I can go to Cameroon according to sanitary conditions in October, so very soon. So I will be able to meet in person with the users.
Yes.